Hi everybody, and thank you very much for joining today's webinar. We're going to begin very shortly. We'll just allow anybody who hasn't joined yet a few more minutes to overcome any technical barriers. Thank you. We'll start in a moment.
Hello everybody, good afternoon. This is Nina Renshaw at the NCD Alliance. I think we're about ready to start this afternoon's webinar on tackling NCDs in workplace settings in low and middle income countries, call to action and practical guidance. Thank you all very much for joining us this afternoon. If you're not familiar with the way we run our webinars, you have the opportunity to ask questions by typing it in the questions box, which is in the pop-up on your screen for the webinar software. So please do, as we go through this afternoon, take the opportunity to do that as any questions strike you, and we'll gather them up and moderate those in the Q&A sessions throughout the next hour and a half. So my name is Nina Renshaw. I'm the Director of Policy and Advocacy at the NCD Alliance, and I'm joined this afternoon by Roberta Bosargi, who is Head of the Urban Health Initiative at Novartis Foundation. They have partnered with us on a report on this topic, which we published a little while ago with a focus on low and middle income countries. A few words on why this is an important topic for the NCD Alliance. Obviously, work is where the vast majority of us spend most of our time and energy, so it's increasingly important to tackle health issues at the root, and some of that might come from our working environment. Nevertheless, the working environment might be marginalised or a missed opportunity for health promotion and well-being, which is something we recognised quite a while ago. We have previously produced a report on workplace health and NCDs that was more focused on high-income countries, but we recognise that there are particular challenges to low and middle income countries, not just comparatively low awareness and comparatively lower capacity to address the NCD burden, but also that lots of employees might be working in an informal sector, which is obviously more difficult to reach via regulation and a more difficult context to initiate programs than in the formal employment sector. So we did, with the Novartis Foundation, launch this report, which is developed in collaboration, to investigate where the opportunities are, to present some examples of good practice, and especially ways of working together across civil society, government, private sector, under a whole of society approach to improve health and prevent NCDs at cause. And to take on that responsibility for shared health and well-being through these kind of innovative partnerships. So this is the kind of thing we're going to be exploring in more depth today. I will take the opportunity to introduce Roberta, who will also be speaking during this call. At Novartis Foundation, Roberta leads a multi-sector initiative for cardiovascular health called Better Hearts, Better Cities, and she's also responsible for setting up a multidisciplinary collective initiative in low-income settings. So welcome, Roberta, over to you.
Janine. Thank you very much, Nina, and I'm delighted to be part of this panel today. As Nina kindly introduced, I represent the Novartis Foundation today. For those that are not familiar with the work of the Novartis Foundation, the foundation is the not-for-profit arm of the Novartis Corporation. And in the NCD specific area, our work spans across a spectrum of programmatic intervention, from piloting and scaling up innovative models of care to initiatives like the one I'm leading for multi-sectorial action to strengthen health systems. Our initiative spanning across 3 continents, so Asia, Africa, Latin America in low-income settings, and as Nina said, and across all this geography, no matter the difference in infrastructure, what struck us is the strain that the NCD epidemics is bringing onto the very limited resources of health systems. And in this context, that the foundation realized the potential of workplace settings for health promotion and care. We have seen from history example like HIV, where employers played a critical role in tackling the public health challenge. And that's what pushed us to come together with the NCD Alliance and develop a report that we hope can help raise awareness, create an advocacy tool, but also share some practical guidance that can be helpful in low-income settings to catalyze action. So I want to thank everyone for calling in today. I hope you all become advocate for the importance of workplace health, and I look forward to your engagement.
Thank you very much, Roberta. So on to the objectives for this afternoon's session. We have 3. First of all, to recognise the potential of workplace health in addressing non-communicable diseases, to explore, as we've said, some of those successful approaches that have been used in low and middle income countries to enable and accelerate implementation of workplace health programs, and to identify the role of different stakeholders and how we can all be involved in implementing workplace health solutions. The structure of this workshop, how we're going to achieve that. First of all, we'll discuss those practical approaches. We'll explore that with different speakers. My colleague Jessica Beagley from NCDA and Roberta from Novartis Foundation. We'll talk about leveraging the potential of the workplace to address NCDs, challenges to establish workplace health, and making the case and how to scale up implementation and opportunities. Secondly, we will have 3 case studies from the field, workplace health in action. Firstly, from Dr. Nalini Saligram from Roguia World in India. Secondly, Ida Nidione from PATH based in Senegal. And thirdly, Chris Kalitz from the American Heart Association. The lessons, despite coming from the US, are very much still relevant. Thirdly, a framework for action and sharing of wider good practice, and that will be back over to Roberta and my colleague Jess for an interactive discussion. As I said, after each of these sections, you will have the opportunity, we'll gather up questions that arise during each of those, and then we'll have a moderate Q&A session with each of the speakers after each of the those 3 sessions and address those in turn. So please do use that question box functionality as we go through. Thank you very much. For part 1 then, I'm going to hand over to Jess and Roberta to talk us through practical approaches as are outlined in the report. Thank you, Jess.
Thank you, Nina. On to the next slide, please. So I think it's obvious to everybody on this webinar that NCDs are not just a health issue, but also an economic and a sustainable development issue, and this is particularly a challenge in lower middle income countries. And the next slide again, please, one more through. Thank you. And it's really important to consider this not just in terms of entire national economies, but also particularly that the relevance this has for employers. So we know that it's expected to cost $7 trillion in low middle income countries alone from 2011 to 2025 if we don't change our course of action on non-communicable disease prevention and control. But even just in the UK, looking specifically at businesses, and sorry that this is a high income country figure, it's often difficult to find the data that we need in low middle income countries. There was a cost of $5.3 billion just to people who survived cancer not being able to return to paid employment. And you can see the statistic below there, that 57% of people diagnosed with cancer had to give up work or entirely change roles. And this just brings home how important it is to be considering support to return to work as part of more comprehensive workplace wellness and workplace health strategies. It's not just about what happens in the workplace to keep people well, it's about support through times of illness as well. And of course, another better known stat is that 40% of people that die from non-communicable diseases are in their most productive years. So this is particularly a challenge for national economies. The converse is also true though, so all hope is not lost. We know that healthy workforce is a driver of sustainable economic development, and investing in staff really does pay off. And you can see here the difference and again, I'm afraid this is a UK example, but 325% increase was seen for companies that were investing in workplace health programs versus a 105% increase being the market average. And this is relevant for employers too, because not only does it help with having a stronger workforce, it also helps with staff retention and having continuity of employees in that regard. We'll talk about this statistic in a bit more detail later in the webinar as well, but only 29% of organisations worldwide have implemented a comprehensive health promotion and wellness strategy. And there is uneven uptake across business types and different resource settings, whether that's SMEs versus informal employment or really large multinational companies, and also the country that they're based in, whether that's a high income setting or a lower middle income country. Thank you, and the next slide, please. And one of the most crucial things about the workplace is that it really brings together interests from across different sectors, and we're always talking in the NCD community about how crucial it is to be having a multi-sectoral and intersectoral response, and workplaces are somewhere that unite businesses, governments, and also civil society. So it's a real melting pot for collaborative action to drive progress and to meet people where they're at. But just because this is a potential doesn't necessarily mean that it's always the case. And we can see that NCDs in particular, even within workplace health programs, are not necessarily recognised as a global priority. That's okay, the next slide is great, please. Thank you. Back to the map, thank you. So in low middle income countries in particular, we can see that there's a lower focus on NCD within workplace health programs than there is at global level. And just as we can be learning from the HIV response in the NCD response more broadly, this is also applicable to workplace settings, and we can look at what's worked with measures to address HIV in workplace settings and how we can both draw on good practices in this regard, but also to be making sure that we can integrate NCDs into existing platforms for addressing HIV in workplace settings as well. Next slide, please. And with that, I'm going to pass back to Roberta. Thank you, Roberta.
Okay, I think I was muted. Thank you. Thanks, Jess. And as you have heard, I think the business case for workplace health is pretty straightforward, right? Whether it is in terms of reduction of absenteeism, increasing of productivity, long-term health of the employees. The reality, unfortunately, is that the uptake and progress are very, very slow. I think if you look at multinational organizations that are, by definition, the organization with the higher level of resources, only 69% offer some form of health program. This might mean an incentive to physical exercise or subsidize a healthy meal, and also the differentiation across geography is quite striking, with high level in high income countries, but still a very low uptake in continent like Africa. However, if you then deep dive and look at the organization that offer a comprehensive program for wellness and health promotion, and by comprehensive, what we mean is a program that is integrated into the organizational strategy and integrated in the long-term growth driver for the organization, then the statistics and the percentages drop to only 29%. Why is that? I think some of the introductory note from Nina and some of the point that Jess mentioned point to some challenges. And during the drafting of this report, we identified some macro national challenges and some micro. Next slide, please. So a national level, I think, is in line with what we were saying before. I mean, the high level of unemployment and the weight of informal sectors create also kind of a hurdle in the initiation of health promotion activity. But I think what is also very, very critical, plays a critical role, is often the lack of health data that, in particular in low-income settings, prevents from articulating business case that can really trigger policy intervention and action. I think Jess mentioned one of the challenges we faced while we were developing the report was the access to data from low-income countries. And this is a national level, kind of ingrained in the difficulty that there is for surveillance, and in particular for surveillance for NCDs. That is still a relatively new area of focus for many of the low-income settings, but it's also true at micro level. So if we look at organizational challenge, and we can move to the next slide, I think data also plays a critical barrier, in the sense that very rarely organizations measure impact in a thorough and long-term way to make sure that investment in health programs gets looked not just as a cost and as a benefit for the employees that gets cut as soon as there's an economic downturn, but as an investment. And the long-term focus on health, until the long-term focus gets ingrained into a proper growth strategy and impact is measured as rigorously as any other commercial initiatives, initiative like a workplace well-being and well-being strategy will struggle to get the full executive and board support, and will struggle to come out of the accountability of HR, where it often sits, rather than the C-suite. There is also another element that we found in analyzing case studies in the report, and was the engagement of the employees. When health initiatives are put in place, are very much one-size-fits-all, cascaded top down to the employees, rather than engaging employees and targeting initiative and making them part of the design and part of the owner of the program. And lacking and struggling to acknowledge that this is a very sensitive area where the anxiety and the fear of discrimination also prevents the employees to engage and to participate. So when we spoke with people affected by NCDs, and we can see on next page some of the quotes that we got from the interviews. So the fear of sharing a disease, to being worried of being discriminated, or the fear of early retirement, and therefore the impact that this can have on the economic welfare of the family. It is a sensitive area, and is only bringing people living with NCD at the center of a design of a long-term strategy that the program can be successful. And this is just the tip of the iceberg, because it doesn't even surface the attitude and the social cultural determinant of health among the population that are not ill, but are exposed to very, very high risk factor. risk factors. So in a nutshell, I think there are some structural challenges that can create an inertia for action in this area, but it's only from the collective engagement of employees and governments and organizations that these challenges can be overcome in recognition of the opportunity of integrating workplace settings into the broader provision for public health. I'll stop here because I think we have the opportunity for the audience to ask questions.
Yes, indeed. Thank you very much, Roberta and Jess. Some people have flagged that they're having difficulties with sound. We will, I think, send a message to the group. If you can only hear intermittently, then we would suggest log out and log back in again, and you have the option to select computer audio. So if you're having any trouble, that would be the suggestion, and we'll maybe put that on the screen as a message as well, so that people who can't hear this will know. Questions from this session. We haven't received many so far, so I would encourage you to please do ask if you have other questions to Roberta and to Jess. There was a question early on about could we get statistics for Africa? I think that was then subsequently addressed in a later slide. If you want to comment, Roberta or Jess, on the availability of data from different continents a little more. Roberta's touched on this, but is it more difficult for some regions than others? And what can we take from that slide with the global percentages on provision of workplace health and different regions?
Yeah, thanks, Nina. I think the only thing I would recommend is if you download the report, all the sources and more, and case example from all the continent, everything that we could find is referenced in the report. Where we couldn't find a reference and it was more anecdotal, we have removed it from the report. So I'm pretty confident that if you go through you practically see whatever is publicly available and in one of the languages that we could understand. Of course, it was a bit difficult to dig into evidence that was in I don't know, in languages like Mongolian, for example.
Thank you, Roberta. We've had a few questions or a few points made in the question box. Thank you very much for those. Subhash Ghosh has raised the point that NCDs are highly dependent on clinician and diagnostic requirements, which acts as a barrier for surveillance, prevention, early diagnosis and treatment. Mutoni Mate has asked, where would one go to access the data and statistics about specific NCDs, economic empowerment, uptake? And I think as a follow-up question, Subhash has asked how countries could work on those areas. So I think that's in relation to barriers to surveillance, prevention, early diagnosis and treatment. Could I put those back to you, Jess or Roberta?
Yeah, Nina, can you repeat the question maybe one per time, or just to think, just to make sure that I got them all?
Yes, sure. Okay, there's more coming in now as well. I will try and group these together. So the first one, NCDs are highly dependent on clinician and diagnostic requirements, which often act as a barrier for surveillance, prevention, early diagnosis and treatment. And the question is, how could countries work on those areas?
Okay.
There's another question.
Okay.
Where could we go?
Go on, and then I can try to answer more than one. Yeah.
There's three now, so I'll give you the three of those and a little time to think on them. Secondly, there's a question about where we can go to access data and statistics about specific NCDs, and uptake of these kind of programs. I suppose the data from the report, and the third question, are there any examples of legal frameworks that protect employees from discrimination if they're affected by NCDs?
Okay, maybe I can answer some of the question on data. So as we discussed, access to data is challenging, and not all countries have a good surveillance system in place. I think in some low-income where we have found that the STEP survey, the WHO-sponsored STEP survey for NCDs, was instrumental to track the prevalence of NCDs and some of the risk factors. So that was, in some of our programmatic work, a key starting point. Where we didn't have access to kind of standard surveys, population-based surveys, we have had to kind of paste different sources. What I mean is, I think many countries are coming into the e-health era, where so the focus and the prioritization on national surveillance is increasing. But until the system is fully functional, we have, I think, one way to get started is to work with some provider and some employers and start creating kind of a baseline based on statistical population samples or research. I mean, in the case of the Novartis Foundation, where we have programmatic activities, we have invested into some research to work with the government to do a baseline and to do a baseline epidemiological survey and baseline. In some countries, the academics or the societies of cardiology are a very good starting point because they have access to multiple research that can help provide a good overview of both prevalence, incidence, and level of control. So I think it depends on what's available country by country, but I would say as a starting point, any national survey, population survey, academic research, but society, professional society.
And if I can come back to the question on whether there are examples of legal frameworks to protect employees from discrimination following diagnosis with an NCD. So I'm fairly certain that in all of the research we did for this report that we didn't come across any examples in lower middle income countries of this, although it was identified as a priority for promoting better workplace health. But I think in this case it might sometimes be helpful to look at what's being done outside of lower middle income countries. And I know that in the UK it's illegal to discriminate against an employee based on their diagnosis with an NCD or any other disability. So I think there are hopefully some transferable lessons that can be learned there, and that's under the Equality Act in the UK.
Thank you very much. We have had one other question in this session, but I think I'm going to put that to our speakers for the second discussion now, based on their direct experience. That question is, what can be done to reintegrate people living with NCDs into the workplace? So I'm going to put that to our incoming speakers, the first of which is Dr. Nalini Saligram. She's the founder and CEO of Roguia World, which is a global health non-profit committed to changing the course of chronic diseases. Nalini is an Ashoka Fellow and the co-chair of the Task Force on Women and NCDs. She will tell us a little more about her organization, Roguia World, but that designs and implements scalable science-based diabetes prevention programs in Indian schools, workplaces, and the community. And we're very excited to hear from you, Nalini. Over to you. Thank you.
Thank you very much, Nina and Jess, for this opportunity. So Roguia World is the name of the nonprofit I founded 8 years ago. Roguia in Sanskrit means living without disease. So we are a chronic disease prevention, NCD prevention nonprofit. We work primarily in India. And next slide, please. If I can have the next slide. Following a model called the Doorstep health approach. Yes, thank you. Where we are taking prevention to people where they live and learn and work. We are working across large populations in India. It's not pilots. and we are taking it to prevention, taking it to people so that they don't have to look for prevention in their doctors' clinics. This is a community-based approach, and we go directly to school children in schools. We work with people in the workplace, and we take through text messages and other efforts, reach people directly in their homes as well. So it's a very encouraging model for us. I'm really pleased that we're beginning to have some traction in a country as complex and large and difficult to operate in geographically as India. Next slide, please. So what have we achieved? We have actually a reach into 4 million people, and we feel we have evidence that we have helped about 400,000 of them lead healthier lives. It's because of our work. So the text message program in diabetes, with that we have done outreach to 1 million Indians, and now it's ongoing with 300,000 more. And we know we have a 20% impact. We have actually published that paper. In schools, we have reached 15% impact. We're currently in about 150,000 kids programs ongoing. In workplaces, we have 116 companies in India that span 2.5 million employees that are part of our Healthy Workplace program. And of them, 29, so about a third of the companies are at our what we call platinum level. In addition, we have a program called My Thali, which is a My Plate, the equivalent of the US My Plate, where we are teaching people what they should eat and in what quantities at each meal, literally translating the National Institute of Nutrition guidelines for India from the complex step pyramid to an easy to understand picture with the familiar plate and small containers that every Indian knows, the thali, to communicate that. So all of these programs also are integrated with our Healthy Workplace program. So next slide, please. Yes. So this is an example of the number of some of the companies and groups that have joined us. We can't do this alone. We have 12 people working with us, so there's no way we could have achieved all this by ourselves. I will point out Cigna and Hans Foundation are our biggest backers. For our 10,000 women study, we got support from Novartis, significant support. And I want to point out a couple of the companies, especially Indian Railways. It's India's largest employer, 1.3 million employees, and they are one of our healthy workplaces. And you can see several of the other groups and companies that have supported us. Thank you. Next slide. So why did we get into workplaces? Couple of reasons. You've heard, the viewpoints of several of the previous speakers already, but in our case, in India, we know the average, the country is young. 2/3 of India is under age 35, and half of India is under age 25. And that age group is very important, and they are the working people. And so the group 15 to 64 is going to grow to about 870 million people in 2020. So this is a huge number of people. One other point, and that is Indians get diabetes in their 20s and 30s now, about 10 to 20 years earlier than people in the West. So where do we find that 25-year-old who is our target for prevention? It's important to get these healthy habits adopted by people before they get diabetes. And if they're getting it in early 30s, then we should find the 25-year-old. And where do we find the 25-year-old in workplaces? So for several reasons, including the fact that with commute times being so long in urban India, people really do spend much of their day at work. So why don't we use the workplace to do our work for us and to mobilize their own employees in the fight against NCDs? I also really feel that everybody was talking about multi-sectoral action, and hey, we have invited the private sector and the public sector to join the fight with us. So next slide, please. So this is just a very quick overview of our Healthy Workplace program. We have been doing this in India since 2013. We have 116 companies with 2.5 million employees now in this program. The process begins with the company reviewing the criteria and actually formally applying to us. We have a rigorous and a robust, a transparent assessment process. We actually visit every company that has applied and go with a 3-person team, 1 person from Roguia, 1 person from somebody with a medical background, and an industry expert. All these people will visit the company, spend half a day, and understand their programs, and then on the spot, the 3-person team gives them the level. And the levels are the following: bronze, silver, and gold. And we have 5 criteria that we developed, co-created in India with industry and public health people. We had a workshop, a day's workshop in 2012, where we actually all sat down and said, what is it that makes a company healthy? What would make a workplace healthy? And we started from scratch. We didn't want to impose European and American standards on Indian workplaces. We wanted to see what would work in India. So those are the 5 criteria. Ban tobacco use, encourage healthy eating, increase physical activity, improve work-life balance, and does your leadership really endorse healthy living? So those criteria across 3 levels, bronze, silver, and gold. And then we have, these are qualitative assessments of companies' employee health programs. And then we have a platinum level. Now in the platinum level, we actually score for the health program. So we ask for data. We ask companies, please tell us how many people participate. Please tell us, do you report on employee health to your employees, in your annual report? Do you communicate it to your board? If so, it's possible that your employee health is part of your growth strategy. If you don't communicate it, then it is not. So that's evidence for us that, hey, there is some real strategic importance given to employee health. And then we ask people for a detailed questionnaire on to gather their data. Now, with that, we give them the platinum level if they are scoring for several of these efforts. So the point I want to make is, if you're collecting data and you're reporting on it to us, you can get to platinum. If you're not collecting data, you can't. So we don't sort of score yet on outcomes. So better data will get you better marks. We still don't have that. We are just saying collect data. The fact that you're becoming data driven is important for us, because then year on year you will show improvement. Literally, as everybody has said, and Margaret Chan famously said, what gets measured gets done. Yes, we believe that. So what gets measured, we want to make sure you're measuring your employee health programs, participation, as well as how many complete the program. And we have a whole bunch of questions that we go through. We score for mental health, community health. We score for programs like smoking cessation. We score for the strategic importance of health in the company, and so on. So platinum level was started 2 or 3 years ago, and the Hall of Fame is a new level we want to start next year, where year on year platinum data is supplied to us, and the company really becomes a champion of workplace health. Next slide, please. So the next slide will show you the criteria that we have been using. As I said, these were co-created with industry and public health people in India. And it has these 5 categories, including tobacco and physical activity, healthy eating, and I said work-life balance. And this shifting mindsets is the leadership endorsement. And you can see there's increased rigor from bronze to silver and from silver to gold. So a company that meets gold should have met 80% of each of the previous criteria. And we know because we go visit them and examine them in a 2-hour presentation. So next slide, please. So just wanted to show you some of the data that we're gathering from the platinum companies. This is a snapshot of the 2018 platinum applicants. We had 7 companies this year that applied. And we have found, encouraging trends of the data they are giving us. A 28% reduction in smoking or tobacco use. And you can see 17% increase in those that completed health risk assessments. A very encouraging increase in the number of employees who exercise regularly, and so on. So this for us is really encouraging, and we want to build on that year on year with the different platinum companies. So for us, this is sort of the goal: get all our companies to become platinum, get every healthy workplace in India, anybody who joins us, to strive to be at the platinum level. That means they're tracking data and reporting and measuring it. Next slide, please. So I wanted to spend a couple minutes on the lessons we have learned. So as you can see, our process is, recognize companies. Oh, we have an annual conference and an award event where we give trophies to these winning companies in front of their peers. So our process is quite simple. You review our criteria and you tell us what you're doing for each of those criteria, and then we'll come and visit you in your company and give us half a day. So this is a snapshot. We'll come back to that. So the important thing is the process has to be simple. If the entry point is very hard, or if you give companies a list of 20 things they must do, they are going to put it off. So because our process is easy, we're getting a lot of companies to join us. And yet, though, the health and well-being of employees is not yet front and center for these companies. They are more reactive. They're focusing on healthcare, and they are not yet becoming prevention focused or proactive about it. We have had to build arguments for what's in it for me. That's the question they all ask. And while some of the data on improved productivity and return on investment from the Harvard study are all there, it's still very, very difficult for the HR head or the CEO to say, yes, I'm going to join you guys for this extraordinary benchmarking effort you have started. Very, very few get that, and then but we've had to build that argument for one person at a time, and it's hard. It's very, very hard because we don't have that kind of data in India. But where we feel we have scored is that we are considered partners and not vendors. So we're not like an employee a corporate wellness vendor. We truly are considered partners, and I think that has helped us. We are currently seeking endorsement from a credible industry association. We don't have that so far. We have Indian Association of Occupational Health. We have Public Health Foundation of India as our partners on this effort, but we don't have, say, Confederation of Indian Industry or NASSCOM or any of the big industry associations, and we feel we need that because it's very difficult for us to convince the companies then one at a time. The other issue we face, and organic Roguia funds have been used so far to support this program for the last 6 years. We do get some sponsorship funds for our annual conference. We do get some small, modest support from the companies participating in this program. But in general, companies don't like to give donations in order to get awards. That's how they view this. Some companies, and then in India, there is a CSR mandate law, so companies are supposed to give 2% of their revenues for corporate social responsibility work, but this program doesn't quite fit in that because employee health is not ready, doesn't qualify for CSR support. And then we are currently investing very much in building capacity. We realized we need salespeople, we need professional business development people to really convince the HR and business leaders that this is an important activity for your future. And so therefore we are building capacity. And the last point is that I want everybody who's doing this work to believe in the mission, because if you believe in it, then it will happen. And I really do feel that the culture of employee health is spreading in India because of Arogia's work for the last 6 years. So next slide. Just to tell you that every year we have an annual conference. We just finished one November 14th and 15th. We always do it around World Diabetes Day. We want to mark World Diabetes Day. With this program, we give away trophies in the evenings to winning companies. We have panel discussions. This year it was on 2 days. November 14th, we had a session on nutrition and Maithali, and in the evening afternoon on metrics. The evening was the award event. The next day we had a massive session on mental health in the workplace, and we're really encouraged by the interest in Indian companies in mental health, in advancing mental health. Thank you very much for your time.
Thank you very much, Nalini. This was fascinating, and I will pass on congratulations that we've been getting in the question box to you for such an excellent program. It's really interesting to hear about this. I will give you all a few moments to ask any other questions to Nalini about this program, if you like. And in the meantime, we've also been asked if we will be able to share the presentation materials after the webinar, and we certainly will. So you'll be able to use those. Any more questions for Nalini? In which case, I would have one, since there's no non-forthcoming in the chat. On the aspect, what we were asked earlier on about the integration of people already living with NCDs into the workplace, is this something that you work on, and what are your experiences of maybe the challenges and barriers faced in the Indian context?
Right. We haven't quite focused on that, Nina, but it's an important point. We can take that up next year. But I do want to comment on the efforts at least one company is making to reintegrate people with mental illness back into the workforce. So in Bangalore, in India, there is a very large National Institute of Mental Health and Neurosciences. So the company, this company is called Infosys. They actually offer internships to people who have undergone treatment at NIMHANS and who are, even if they're not their own employees, they offer them 6-month internships, because putting on their resume that they have Infosys experience will help them get a job. So they are absorbing these interns, and I think it's it's a wonderful effort that a lot of companies can copy. And we brought Infosys to a global conference on workplace health, and another company asked to follow, to connect with them so that they could learn exactly what they do, what the academic institution does, so that this can be copied. I do think this is a good best practice, to offer internships to people. Thank you.
That's great. Thank you very much. Yes, we've got a few more questions flowing in now. I'll group a couple together for you, Nalini, and then you can answer them in turn. More messages of congratulations for such a simple but effective program to you as well. Right, a few questions. Tuan Pham is asking, do you consider screening and diagnosis in the workplace? Nicole Rayla has asked, can you imagine this model working at a community level, if a community applies for participation? Abby Bejo is asking, can you talk us through the steps of how you got started? Was it with just one company, or was it with a working group? And I spotted one more. Oh yes, do you have any experience from the informal employment sector? That's from Subhash Ghosh.
Okay, all right. All great. Thank you.
Mm.
So for screening and diagnosis, we don't do it. Not everybody can do everything. We are very clear what we can't do, but we have partnered with others, and most of our companies do have employee health program, screening and diagnosis partners themselves, but we have partnered with one called Vitor Health that has a diagnostic kit in a backpack. And so they can go to desk sites, they can go to factory floors, and in 10 minutes they can do a very comprehensive blood and all sorts of measurements right on the spot on the employee, and give the employee a little credit card printout type slip, and also give the company a full view of their employee health program. So we are partnering with companies to do that. On the community level, it would be awesome. I would love to see how an entire set of villages or a community could become a healthy workplace with our assessment process. It would be really great. We haven't done that. We are thinking of big, large tech parks. So there are huge office complexes in India with, so many companies and tens of thousands of employees. So we are looking at how can we make a tech park, an entire tech park, a healthy workplace. How we got started, it was one company at a time. Each one of these 116 has been through very painstaking follow-up, seeking introductions from people who know people, and only very, very few have actually reached us on their own. So it is very, very hard work. I wish there was a simpler process. As I said, if a big industry association could have adopted us and sent information to all their members, I think it would have been simpler. But we have done it the very hard way. And the informal sector, yeah, it's a very, very difficult thing. What we are tackling is the part that is formal, and it's a small part of the workforce, fully appreciated. There are some associations of street vendors, for instance, that we are looking at partnering with. But I do want to mention the Government of India. There is the Food Safety and Standards Authority of India. They are engaging also with the informal sector, and they have shown a real big interest in us. We think that with them, we can support a healthy cafeteria award, for instance, get the companies that have cafeterias, not just to promote nutrition, which is important for us, and adopt My Thali, but also to make sure that the cafeteria is hygienic and food safe. So we want to promote all these efforts, and we are beginning conversations with the Government of India on that.
Great, thank you very much. If you don't mind, there are a few more questions come in. If you have another few minutes, Nalini, that would be great. One of those questions is, you already touched on presenting the case to the companies, what's in it for me? So one of the questions is the investment by the company offset with return on their investment in the future? And how do you present that to them? Another really good question, does your certification program somehow evaluate whether companies aren't discriminating against their employees that have health conditions? And maybe a final question on this section, how do you navigate companies that are not compatible, part of broader associations or partner companies, in the sense of maybe companies that sell unhealthy food or sugar sweetened beverages, maybe have tie-ups with tobacco companies? How do you screen for that and try to navigate that?
Right.
Great question.
Yeah, all very good questions. So on the ROI question, so our Platinum program is designed ideally to arrive at this ROI figure for companies working with individual companies. Now you must realize that there's some things they can't tell us, and it's proprietary. So we want to work with them and arrive at this ROI. We're not there yet. What we are trying to do is give them a bit more qualitative assessment of a value on their investment. We do ask for budgets. We do ask them, how much do you spend on employee health programs, and how much is your health budget? So we do ask them those questions, and we are working with them. I cannot tell you that we have arrived at that. We have 29 companies that have become platinum, but we hope to get there. We're not there yet. On the discriminating, again, I want to give you an example of the mental health. We haven't quite taken this up on the cancer and diabetes and other questions that you guys had. So I will take that up as a take home for me, going forward. But on the mental health, see, we had this conference, and we had a person with a bipolar disorder, a working person with bipolar disorder, come and talk about his disability and how difficult it has been for him to retain a job once he tells the HR person that he has this. And he appealed to all the companies and leaders there in our conference that they should make friendlier practices, HR practices and policies. So we, from our side, we will be sharing with the companies that appeal, that that ask, and we are going to get more and more CEOs mobilized on this. We are partnering with a group called One Mind on this effort, and the aim is to get CEOs. It is a decision at the C-suite. If the CEO says, yes, I'm willing to invest and make destigmatize mental health in my workplace because it is affecting a third of my people, so we are going to recognize this and tackle it head on, well, perfect, then everybody else follows it. And that's where we are starting. We're getting these company CEOs more and more mobilized. You'll hear more from us on this. On the companies, the food companies and tobacco companies, we have not been approached by Pepsi or Coke to become a healthy workplace so far, and we ourselves are not going to go there. Definitely not to the tobacco companies. So we have not had such a situation so far. But thank you for the question.
Great. Thank you very much for this case study. It's been very insightful, much appreciated, and thank you for fielding all those questions. We're going to move on to the next one. Our next speaker is Ida Rose Nadion. She's the lead of the NCD program PATH in Senegal, and she's also the program coordinator of the Better Hearts, Better Cities program. And we look forward to hearing about the Workplace and School Coalition in Senegal from Ida. I hope the technology is working.
Yeah, thank you. Do you hear me well?
Perfectly, thank you.
Okay, thank you for giving us this opportunity. It's a great pleasure for me to make this presentation about Better Hearts, Better Cities initiative, and particularly about the work we are doing with the companies and schools in the coalition to fight against hypertension. Thank you. Next slide, please. Slide, please. Okay. So considering the importance of hypertension in the world, Better Hearts, Better Cities is a Novartis Foundation initiative to improve cardiovascular health in low-income urban communities. And 3 cities have been involved in this program in Mongolia, Sao Paulo in Brazil, and Dakar in Senegal. Specifically, in Senegal, Better Hearts, Better Cities intervention consider data from the STEP study in Senegal in 2050. Prevalence of hypertension in Senegal is around 30%. And if we consider the population at risk, only 46, oh, sorry, I am in advance. So this slide, yes, get back the previous slide, please. Just to present in the previous slide, go back in the previous slide, to show you the partnership in Senegal Better Health, Better Cities, we have a multi-sectorial partnership with PAS, IntraHealth as implementer partners, CDC and his local partners CRDH for the monitoring and evaluation. And the Ministry of Health and Social Action is the central partners with the non-communicable disease department. So our work is based on the strategic plan of the MOH to address non-communicable disease. Thank you. We can move on the next slide.
Sorry, Ida, we have a bit of a time lag on the slides, but
yes,
it has moved on, so go ahead.
Okay. Yes. Yes, what I said previously is Better Health, Better Cities based this intervention in STEP study in Senegal. The prevalence of hypertension is around 30%. And if you look at this slide, you have the population at risk. In the population of only 46% are aware of their status. 17% are under treatment and 8% are treated and controlled. So this graphic shows that there is a big gap between the four indicators we follow. That's why Better Health, Better Cities intervention are specifically around prevention, screening, diagnostic, and treatment and follow-up. Thank you. Next slide. Next slide, please. Okay. So one of our specific intervention is to leverage the potential of workplace program, including the fight against non-communicable disease. So we support Better Health, Better Cities seeds and catalyze their action. We have encouraged employers to embrace our vision of goals in non-communicable disease fighting. We provide technical support and a business case that show that healthy employers means healthy business. Employers spend less on prevention than on care. And we integrate in the program of companies. Companies integrate our vision in their program. Next slide, please. Thank you. So in this slide, we can tell that since November 2017, we launched the coalition with 6 members at the beginning, and now we have 15 members. We potentially can touch more than 10,000 people if we consider global staff. Recently, we have involved schools and MOH Ministry of Health as a workplace for awareness and screening. Schools' involvement is very interesting because beyond the employees, we can touch the students. Because schools are educational seats where awareness campaign can provide big impact. We also have created a dashboard, a digital dashboard, to monitor 4 indicators: screening, diagnostic, treatment, and control. Thank you. Next slide. Okay. The key point of the success in the coalition is to find a local champion, and in Senegal it's Eiffage, an international builder company with 1,900 staff. With Eiffage, we have a strong collaboration with the head office and management team. We have organized many activities around non-communicable disease fighting, the celebration of Hypertension World Day with screening and awareness activities. We also have organized a hiking on hypertension fight and a campaign around risk factors of non-communicable disease. This awareness campaign talk about 0 tobacco, 5 vegetables per day, and 30 minutes of physical activities per day. We have screened more than 1,100 participants with Eiffage and other coalition members. And we have also trained the occupational physician in hypertension management with an algorithm based on World Health Organization recommendation. Okay, next slide. We expect that Eiffage will take the leadership on hypertension fight and non-communicable disease in the future, and we hope that as the previous presentation in India, it's encouraging to see that in 5 years, India has been able to build a strong workplace program. We have 1 year background with our coalition, and we hope and expect that in 5 years we can be at this level. Thank you. You can see in the next slide the coalition members list with their number of staff and schools. Sorry, the next one with the coalition members. As you can see, we have the big companies. Eiffage is the leader of this coalition, but we have also other international companies like Nestlé, Dubai Port, and we have also national companies like Soboa, Kotowa, and other companies in builder, food factory, plastic, very different area, and recently with the schools, so we expect to do awareness campaign with staff, but also with the student. Thank you for your attention.
Thank you very much, Ida. Apologies to you, Ida, especially, but to everybody for the time lag we had there with the slides. In the interest of time, what we're going to do now is group the questions also for Ida with any questions for the next speaker, Chris. Chris Callett is going to speak next. He is Director for the Center of Workplace Health Research and Evaluation from the American Heart Association. His responsibilities, apart from leading that center, is also to provide policy evaluation and research to support the AHA's CEO Roundtable, which includes over 40 CEOs from the US's largest companies who have committed to creating a culture of health to improve employee health. He also is the staff lead to AHA's Workplace Health Steering Committee. So we look forward to hearing from you, Chris. Thank you.
Great, thank you very much, Jess and Nina, for the opportunity, and I'm very pleased to follow two really great presentations that really focus on low and middle income companies. And as you said in your introduction, the work that I'm about to present focuses on the United States, which is obviously a high income country. But what I would say is that what our data shows is that there is also a tremendous amount of variation and disparities between companies, especially based on their size in the US. And so there are, I think, learnings even from the companies here in the United States that can be applied either to low and middle income countries or the other way around. So I've really enjoyed the discussion. So Roberta mentioned earlier that the business case for investing in workplace health promotion is reasonably clear, even though we still find ourselves in the position of having to convince some chief financial officers to make that investment in prevention as opposed to treatment. And here in the United States, according to CDC data that was published in 2004, less than 10% of US companies implement comprehensive workplace health programs. And there's new data that will be published any day now. And my sense is that percentage has not increased significantly. And so what we wanted to do as an organization, we've been active in workplace health primarily through promoting physical activity and healthy eating. We wanted to wrap our arms around that and really provide a platform for companies to improve the overall quality and depth of their workplace health promotion programs. So based on what the opportunity was, the strategy that we embarked on in 2014 was to design, test, and then implement what we call a workplace quality improvement framework. And we've done that in partnership with the CEO Roundtable, which is a leadership collaborative that was convened by the American Heart Association and our CEO, Nancy Brown. The current co-chairs of the Roundtable are Alex Gorski from Johnson & Johnson and Brian Moynihan from Bank of America. And so all of these companies have agreed to a common set of standards, and there's a slide that I can speak to later on. Next slide, please. So the tool that we created, which is part of our continuous quality improvement framework, is called the Workplace Health Achievement Index. And as the name suggests, it is a tool that allows employers to participate in an assessment that demonstrates the degree to which they have created a workplace culture of health and well-being in their organization. And based on their overall performance, they receive recognition from the American Heart Association. Very similar in structure to Nalini's great program. And Nalini, it's great to hear you on the phone again. So the way that we've structured our assessment, which is a voluntary online assessment, is the first part involves organizations completing 55 questions, which are 55 evidence-based indicators of a workplace that supports a culture of health. And we've grouped those 55 questions into 7 domains or pillars of workplace health, and they are leadership, policies and environment, health promotion programs, communication strategies, engagement strategies, community partnerships, and reporting outcomes. So quite similar to what some of the other speakers have been talking about. I think these are now recognized as fairly universal domains of workplace health, although I completely agree with Nalini that they do need to be culturally tailored for many different countries. So once companies have completed the answers to those 55 indicators, we then ask them to submit data to us. So I loved what Nalini said about, encouraging companies just to begin to collect data, and we try to do the same thing. And then in addition to that, we recognize companies who provide us with data. We've created a HIPAA compliant cloud environment where companies can upload what we call Life Simple 7 metrics. Life Simple 7 is the American Heart Association's science-based metric that calculates somebody's cardiovascular health, and that composite cardiovascular health score is comprised of 7 components, and that is body mass index, smoking status, diet quality, physical activity, blood sugar, cholesterol, and blood pressure. Once companies have submitted their Life Simple 7 metrics safely and securely into our cloud environment, we generate an aggregate employee heart health score for the company. And then we also measure improvements in that heart health score for the organization over time. So that's the basic framework of the tool and the assessment. Next slide, please. So this is just a flow diagram that summarizes the quality improvement framework at a very high level. So the point of entry is to assess the quality of your workplace health promotion and well-being environment using the Workplace Health Achievement Index. Companies who sign up to our program have access to a number of American Heart Association resources that help them to make changes to their environment. So for example, we have a resource that is called the Healthy Food and Beverage Toolkit, which allows companies to score themselves in terms of what their internal food and beverage environment is like. And then we offer them a step-by-step guide to improve that environment, primarily through improving the quality of the food and beverages by, for example, cutting out sugar-sweetened beverages, increasing the amounts of fruits and vegetables that are offered, and so forth. And so from a year-to-year basis, companies have time to look at their benchmark data, and I'll get to that in a second, to assess where their major gaps are, and then to implement policies and programs that they haven't been able to in order to improve their performance. And then every single year we recognize companies who've achieved various levels of excellence on our index, and we at the moment have bronze, silver, and gold. We are about to create a platinum category, very similar to the way that Nalini and her team have thought about it. We have several best-in-class companies now who have been gold for several years, and now that we have a lot of data, longitudinal data from over 1,000 companies, we're able to see what the distribution of the recognitions are and the points, and we're going to be creating a platinum category. And we give organizations dashboards and benchmarking reports so that they can see how their performance on each of the 7 pillars and also the 3 performance metrics compares to their peer companies by company size and by industry sector. Next slide, please. So this is just a high-level slide to show you the journey that we've been on over the last 3 years. We've got over 1,200 companies that are now participating in the index. Not all of them managed to complete. In order to be considered complete, companies need to complete all of the 55 culture of health indicators. But we've been reducing the non-complete companies year on year. Based on the over 1,000 companies have completed, we have a reach of about 6.5 million employees, and we've seen a steady growth in the number of companies who are providing us with, with their employee data. And I'm sure that everybody on the call appreciates the challenge for organizations to provide that data, not only from a technology standpoint, but also from a compliance and data privacy standpoint. Next slide, please. So I wanted to give you an example of how we're able to benchmark and analyze the index data year on year. This slide is just one, shows 3 of several physical activity questions that we ask in the index. So, for example, does your company promote the use of recreation centers and gym memberships, either by providing a gym on site or offering discounted or reimbursed memberships? And then I won't read the other 2. And in this slide, I'm showing you the adoption of those policies by company size, starting on the left-hand side with companies with less than 50 employees to then companies with 5,000 or more employees. And across all of the 55 metrics in the index, we definitely see a very strong relationship between company size and the likelihood of a company implementing any given policy or program. In this slide, the first 2 questions, there are significant differences based on company size. Managers allowing employees time off during the day to engage in physical activity is not significant. Next slide, please. And then we also benchmark by industry sector. We use the North American industry codes. And in this slide, I've just created smaller categories just to make it easier to interpret. So we've got health, education and health companies, goods manufacturing, IT and finance, leisure sector, transport and other. And I won't read the slide, but basically what the slide shows, if you look at the p-values on the right-hand side, is that there isn't that strong statistical relationship between companies in various industry sectors and the adoption of physical activity policies in this case, but it's a relationship that we see repeating itself in the other metrics. And based on what some of the other speakers have said, these findings are not particularly surprising because we know from data across the world that small companies do not have the same level of financial and human resources to implement comprehensive workplace well-being programs. So I think one of the challenges that we all have, irrespective of whether we're working in high-income or low and middle-income countries, is really how to support a small and medium-sized companies to adopt perhaps a smaller set of core practices that are highly associated with improvements in cardiovascular health and other health outcomes. Next slide, please. So the table in this slide shows you at a high level what we found between 2016 and 2017. I showed you in the previous slide specific examples of physical activity. When we zoom out to a high level view of the differences between small and large companies, we see that between 2016 and 2017, larger companies improved in 6 of the 7 domains, whereas small companies only improved in 1. So I think that underscores the need to support smaller companies. The other thing that we are embarking on is a formal science review of the questions within the Workplace Health Achievement Index, so that we can update many of the strategies. We also conducted a Lean Six Sigma review, and our client companies are requesting a shorter assessment. So we're going to be looking at ways to shorten the assessment, but still keep it relevant by identifying those strategies that have the highest population health impact. And in the same way that Nalini is, doing some great analysis on the improvements in health outcomes for her companies, we're now embarking on evaluating the health impact of improvements in the index scores, because our clients are telling us that that is of great value to them. And then we conduct research with our partners. We published a paper last year in Health Affairs with Ron Getzel from Johns Hopkins University, and we'll continue to be evaluating the performance of our tool. Next slide, please. That's it. Well, thank you very much, everybody. I welcome any questions you might have.
Thank you very much, Chris. That was great. You've already actually touched on many of the questions that I had lined up on compare and contrast with lower resource settings, so that's great. And also it's come across very strongly the need for SMEs to get more support than the larger companies. That's been very stark here. I would encourage our participants, if you have any questions for Ida or for Chris, our last 2 speakers, please do send them over in the question box. I will skip forward onto the third part of the presentation. We can of course come back to any questions if you have them, which is back over to Jess and to Roberta in just a moment. As you can see, we're coming to the end of our time because we've had such a good discussion so far. So if you can bear with us for just an extra 7 minutes, I would say, and then that'll be enough for us to get to the end of the session. And please do use that question facility, and we will have one last wrap-up round of questions to round off the session. All right, back to you, Jess and Roberta. Thank you.
Thank you, Nina, and thank you everybody for staying with us for this long. I don't think we're even going to take 7 minutes of your time. We'll skip through this last session at lightning pace. So just to talk now, going back to the recurring thing that we've had throughout this webinar about the importance of multi-sectoral collaboration. And thank you to everyone who's touched on that throughout their presentations. It's been really great to understand a bit more detail about how things are playing out at national level. We identified 5 different stakeholder groups: government, employers, NGOs, workers' organisations and media, and looked in the remainder of this section of the presentation at how these different stakeholders contribute to some priority actions that we identified for implementing workplace health interventions in LMICs. So Roberta, I'll pass back to you for these next couple. Thank you.
Yeah, thank you very much, Jess. And I think these pages are just an extract from the report. So I would encourage every participant that is interested in getting started in this area to read from the report, the experience from the organization that we have found, and the differences across different geographical contexts. But just to skip through the key element that we have extracted. So the first thing, we have heard from all our case studies that there are many catalyst for action, and that can depend a lot on the geographical context. That action might start from a specific employer, or it might be triggered from governmental policy intervention, or even from an NGO in the context of a program to strengthen health system. I think what is important and makes life definitely easier in the long term is to align on a vision and on a main common goal across stakeholders. And that will depend a lot on the geographical context. It could be triggered by, as I said, by a government intervention mandating a health screen, a yearly health screen, or it could be mandated by a health priority that could be obesity or cardiovascular mortality. But I think to accelerate action for all the stakeholders to come together and align on priority is paramount to align on the agenda. And then secondly, we can move on to the next page. I think we've heard it both from Nalini and from Chris, the adaptation to the local context in a data-informed and culturally informed way is critical for success. So you see, each different stakeholder might play a different role. However, the effort upfront invested into saying, based on the data available, what is the pain point in the system that can really provide a good what's in it for me across the stakeholder? Is it an issue of absenteeism? Is it an issue, as I mentioned before, of cardiovascular mortality? Is it an issue of obesity of the population? And just corral around that and start collecting data, because if you don't measure, you don't know what the impact is going to be, and you don't trigger action, and adapt to the local social cultural component. So, I mean, I can share 30 seconds my experience from Mongolia, from the work we are doing on Better Arts, Better City, to try to incentivize physical exercise in a country where in the winter the temperature goes down to -30. It would be mission impossible. And so all the stakeholders came together and agreed that the salt reduction strategy was the most potential, that had the highest potential across employers' organization. And so through industry association like bakeries, employers and canteens, there was a common alignment on reduction of salt into the meals provided. So I think the adaptation is key. Jess, do you want to take over from that?
Thank you, Roberta. So if we could shift to the next slide on resources and incentives, that would be great. Thank you. So when we think about incentives, we can think either about incentives for entire companies or for employees. And yet again, we're seeing that there's a lower percentage of companies in low and middle income countries that use incentives than is the case for higher income countries. And in the US as well, there are companies that are able to benefit from tax breaks if they're implementing workplace wellness, workplace health interventions. In Brazil, to shift to a lower middle income country, there are examples of subsidies being given to for healthy meal plans in workplace canteens, and this has led to increased consumption of fruit and vegetables, which is very good to see. And then with regard to catalytic funding for new workplace health programs, this helps to carry through particularly small small companies until they're able to see the returns on investment and start getting funds for the work that's been implemented themselves in a more cyclical fashion. Next slide, please. In terms of sharing learning and celebrating success, public bodies are always excellently placed to be setting an example for wider communities and countries. And at global level, WHO is a good example here with their smoke-free workplaces and also a shift towards more nutritious food in the canteens. Accreditation for business, we heard from Nalini about what Roguia World is doing. And for best practice dissemination, both the work of Roguia World and the Caribbean Coalition is really important here, and an area where civil society plays a key role. And finally, there's also a role for businesses in reaching out to their networks rather than civil society being the the broker and the lead for the knowledge exchange, and businesses themselves can also promote what they're doing to their own networks. Next slide, please. For ensuring follow-up policy implementation, smoke-free legislation is a really interesting one here, because the legally binding nature of the Framework Convention on Tobacco Control means that there's obviously a lot more of a mandate for governments certainly to be ensuring smoke-free zones, and employers have a really key role here too. And once again, NGOs have a really valuable role in developing and publicising materials and resources. Next slide again, please. And this finally is much more about the how on an internal, within any given company, how managers, but really anyone, but especially managers within companies, can be taking the lead to implement workplace health programs in their place of work, and really take the whole of their employee body, or even more senior management, along with them. So there's a need to lead from the top, to engage employees, like we've already heard today, and as part of this, to be assessing their needs and make sure that the workplace health program really delivers on what they need. And then crucially, to monitor and evaluate the outcomes, and to consistently rethink and adapt programs to make sure that they're always meeting the needs of the people that they are intended to serve, and to share successes and challenges to enable others to follow up and implement similar interventions in their own companies. And the very final slide, if we could have that up, please, is a list of relevant resources, and those hyperlinks will be active when the presentation is uploaded online. And we are now 6 minutes over. I'm not sure if there are any final questions, but Nina, I'll hand back to you to pose them if they exist, and to close the webinar if not. Thank you, everybody.
Thank you very much, Jess and Roberta. That's fantastic. We did have a couple of final questions. One was to Chris on the involvement of insurance companies in the US, but I think one of your slides, Chris, answers that. There's quite a few health insurance providers and health sector companies involved in your program. And then we've had a final comment more than a question, which I think is a useful one, actually, as a concluding note. Thanking you for a very useful summary in this third part. The challenges for low and middle income countries are competing priorities for health. There's a lot of drive pushing for workplace health, but it's meeting resistance because of an unwillingness to adapt environments to address outcomes, or inadequate health services to support. I hope these are issues that have come across through this afternoon's webinar. Thank you very much to all of our speakers. This has been fantastic, and a really diverse set of examples. Of course, you can refer back to the report, and all these materials will be made available to everybody following the webinar. Thank you so much, everyone, for your participation, and especially to our speakers. Apologies for the little bit of background noise we have now, and for the small tech fail we had earlier, but I hope it's been productive. If you have any more questions that you would like to follow up with us or any of the speakers on, then please do get in contact with the NCDA Secretariat, and we'll be happy to pass those forward. Thank you very much again, everybody, and have a great rest of your day.